From Redfield Medical Direction, I'm Lynn Nguyen, Associate Medical Director, and this is your Trauma EMS Protocol Review. Since trauma is such a broad topic, we only covered a fraction of our trauma protocols in the July Protocol Review episode. We'll be covering a few more topics in this bonus episode, starting with eye trauma. Your management of ocular trauma is based heavily on a thorough history and physical exam. Important elements of the history includes whether or not the patient uses glasses or contacts at baseline and mechanism of injury. Your physical exam starts with assessing the visual acuity. Of importance is whether or not the patient has abnormally blurry vision, double vision, or vision loss. Check pupil reactivity with a light, followed by a complete neuro exam. Take note of any chemical agents involved. A safety data sheet is helpful if available. Ocular chemical burns are a true ophthalmic emergency and are best treated with copious irrigation with water or normal saline. Delays in irrigation have been associated with higher risk of morbidity related to vision loss and other complications. The key component of irrigation is the volume of fluid, so continue irrigation during transport if possible. In situations of physical eye trauma, globe rupture might be obvious and should be, of course, documented. A detailed exam of the eye should include any noticeable laceration or pupil deformity. If you've confirmed a globe injury, put a hard eye shield on the affected eye and transport. Don't pry the eyelids open for any reason. Give ondansetron to get ahead of any potential vomiting, since any retching will unnecessarily increase the eye pressure. Elevating the head of the bed to 30 to 45 degrees will also help. If the globe is out of the socket, cover it with saline-soaked gauze. We advise covering both eyes in cases of eye trauma to reduce pupillary strain from light. Not every burn needs care at a specialized burn center, but the ones who do really need it. These patients can decompensate very quickly and need proper intensive resuscitation that can start in the field. The American Burn Association last updated their referral guidelines in 2022, providing clear criteria for when a patient needs that higher level of care. First and foremost is the presence of any full thickness burns. Second is if at least 10% of the total body surface area has partial thickness burns or worse. Any burns that involve the dermis of the face, hands, feet, groin, or over any joints also meet criteria. Facial burns with singed nose hairs or stridor are signs of inhalation injury and should be transported to a trauma center if not a burn center. The reactive edema from inhalational injuries will inevitably cause a difficult airway. For both chemical and electrical causes of burns, your first priority should be scene safety to ensure that you don't become a patient yourself. Figure out as much as you can about any hazardous chemical to make sure it is not dangerous to you or your team before initiating contact. If it is safe and the chemical is something like a dry powder, you can start preliminary decontamination by brushing off the dry material. Don't wash it off with water, since this could cause an exothermic reaction and worsen the initial injury. On the scene of electrical trauma, check to make sure any electrical source is ideally cut off, or at least no longer in contact with the patient before touching the patient. Electricity causes thermal and non-thermal burns along its path. You might see tiny superficial lesions on your exam, but these may be hiding deep tissue injury. Standard ABCs apply with the rare exception of lightning strikes, which should be reverse triaged. These patients actually have great prognoses if proper resuscitation is started early. External electrical burns should be treated like thermal burns. Falling back on your basic ABCs, you should have a low threshold to assist ventilations. If there are any neck burns, soot in the airway, change in the patient's voice, or stridor, consider early intubation, with the knowledge that any endotracheal manipulation will worsen airway edema and complicate any subsequent attempts if you aren't successful on first pass. This is one of those times that, if you can't manage the airway in the field, you should think about going to the nearest ER to secure the airway before continuing transport to a burn center. Use the rule of nines to estimate total body surface area involvement in adults. The area of a patient's palm is about 1% of their body surface area. Burn patients are at higher risk of hypothermia due to the loss of the natural insulation that the skin provides. Heat evaporates much more quickly through the exposed burn surfaces. Their abilities to maintain their own temperature worsens if they go into shock, which increases their morbidity and mortality. This is why it's important that you keep the burn patients as warm as possible. Significant burns cause fluid to leak out of the blood vessels, potentially progressing into shock as the low circulating volume reduces blood flow to the major organs. Early fluid resuscitation helps maintain blood pressure and organ perfusion. The Parkland formula has been historically taught as the calculation to be used to determine the volume of fluids needed for burn patients. The Parkland formula is associated with larger fluid volumes that can cause over-resuscitation and in-hospital complications like abdominal compartment syndrome. Alternatively, burn experts came up with a consensus formula, which is calculated by 2 cc's per kilo per percentage of total body surface area, with 50% of the calculated volume to be given in the first 8 hours. Our protocols are based on the consensus formula. After exposing the patient and removing any constricting jewelry like rings or bracelets, you should start an infusion of 0.25 cc's per kilo per percent total body surface area. Lactated ringers are the choice fluid, but normal saline is fine if LR is not available. The hospital can switch to LR without issue. Pain management is critical, but do not administer any medications IM in burn patients. The fluid shifts and tissue injury from burns are what you're treating in the field. The pathophysiology of crush syndrome is similar, in which you are dealing with massive tissue damage that can cause dangerous systemic effects that can be deadlier than the initial trauma itself. Crush syndrome happens when a part of the body is trapped under heavy pressure for a long period of time, usually for at least an hour. The prolonged pressure damages the muscles, which start to break down and release potassium and other intracellular contents into the bloodstream. The real danger often happens when the patient is successfully extricated and the pressure is released. All the byproducts of the muscle breakdown rush into the general circulation and can cause dysrhythmias and acute kidney failure. This is why, if you know that the patient with a crush injury will need prolonged extrication, you should start setting up with IV or IO access and getting a 12 lead. You can think of the management of crush syndrome as treating two diseases. The first is prevention and mitigation of hyperkalemia. You can screen for this by looking for peak T waves on your EKG. Also, if the QRS is longer than 0.12 seconds, or if the QTC is longer than 0.46 seconds, you should treat with a gram of calcium, an albuterol nebulizer, and a milliequivalent per kilo of bicarb. Your second priority is protecting the kidneys, which you're doing with a liter bolus followed up by maintenance of 500 cc's an hour. Unlike burns, normal saline is the preferred fluid in these cases, since lactated ringers have potassium. After extrication, continue IV fluids and pain management. Reassess for any cardiac dysrhythmias, for which you can redose with a gram of calcium if needed during transport. You can consider push-dose pressors if the patient becomes increasingly unstable before you get to the hospital. And that's all we have for this bonus review. This episode was produced by me, Lin Win. Our theme music is by Infraction. As always, feel free to reach out if you have any questions. See you next time.